Okay, so it's about 7:30, so I think we'll get started. Good evening, everybody, and welcome to the Southeast Regional event for the MACP. My name is Samantha Simmons, and I am the Knowledge Translation Officer for the MACP. So I'd like to welcome you to tonight's first event for the Southeast Coast, which I'm really delighted to be hosting, and even more excited to be bringing you Laura Finucane and Chris Mercer as our first speakers. Having looked through the people that have signed up today, I can see that we've got a lot of members. We've also got a lot of people out there who aren't members. So if this is your first MACP event, welcome. So who are the MACP? Well, we're a physiotherapy membership organisation whose members have a specialist interest in musculoskeletal health. The MACP is the UK member organisation of the International Federation of Orthopaedic Manipulative Therapy, or IFOMT, for which Laura is the president. IFOMT set the educational standards of practice in this specialist field of physio. There are several ways that you can become a member of the MACP, and they should be flashing up across your screen as I'm talking. So full membership is via completion of a UK-based MSc course, the portfolio route, or via reciprocal recognition with an IFOMT membership organisation. There's associate membership, and this is for those physiotherapists who are currently working towards full membership, either via an MSc programme or the portfolio route. There is also an affiliate membership, and this is for any physiotherapist who is perhaps not on that pathway with their career, but has a specialist interest in MSK, or is just starting to develop an interest in MSK. If this is you, then I would urge you to have a look at the affiliate membership, because for £20 a year, you can join the supportive community of MSK physios. There are also some excellent benefits that you will get from being an affiliate membership, and this includes preferential booking and discounted rates on MACP or courses. You also get discounted subscription to JOSP, and access to the members only section of the MACP website. And on there you'll find podcasts, journals, research, and training video and educational videos such as tonight's event. So after Laura and Chris have finished tonight, I would urge you to go across to the MACP website and check out how we can support you. You can also follow us on Twitter, and our Twitter handle is @PhysioMACP. Just a couple of housekeeping points before we move over to Laura and Chris. Laura and Chris are very keen to keep this as interactive as possible. So if you could please place your questions in the Q&A section that you'll see at the bottom of your screen. Please don't put them in the chat function. If you see a question that another attendee has posted that you are keen to know the answer, please do upvote this, as we'll try to answer the most popular questions first. Okay, so Laura Finucane and Chris Mercer are both consultant physios based on the South Coast, Laura in Brighton and Chris in Worthing. They both have a specialist interest in serious spinal pathology and have collaborated on numerous pieces of work together and presented all over the world on this topic. This collaboration led to them being involved in the International Framework for Serious Spinal Pathology, which was released last year in July with the backing of IFOMT. So this is what they'll be discussing tonight. So I'm sure that they're going to be very engaging and entertaining tonight, so I'll hand over to them now and enjoy the session. Thank you.
Thanks, Sam. So if I can share my screen, you're gonna have to, that's perfect, thank you. Just bear with me. So thank you for the introduction, Sam. I'm going to talk very briefly about the framework and how we got to where we are with the framework with that particular document, and how we developed it, and how we hope that you'll be able to use it within clinical practice. And Chris is going to talk about some national back pain guidelines around Cauda equina, And then we're going to open the floor up to questions, essentially. So as Sam said, this was a piece of work that was commissioned or we were asked to create on behalf of iFont in 2016. And I think if anybody asked us in 2016, what's this framework going to look like? We had not a Scooby-Doo. We really didn't know what this was going to look like. But what we did know that there was anxiety amongst clinicians around trying to identify serious pathology, and certainly, some anxiety about missing serious pathology. And that wasn't just in the UK, that was really internationally, it was around the world, there was this anxiety. And we also knew that red flags were being called into question. And there are kind of a number of reasons for that, but one of the biggest reasons was because in order to justify the use of red flags, what we've tried to do is establish diagnostic accuracy. So what that means is that if the red flag is present, then it's likely that serious pathology will also be present. So it increases the likelihood or the probability. And of course, we've not really been able to do that, except for a handful of red flags. So, and it's not really surprising when you look at how difficult it is to do a diagnostic accuracy study, because it needs to be a prospective study, and look at some of the pathologies we're talking about. So, for example, in spinal infection, when you've got an incidence of somewhere between 1 and 2.5 cases per 100,000 in a Western society annually, then it makes it really, really challenging to do these diagnostic accuracy studies, at all. So what you're left with is retrospective information and studies and case reviews and studies and things. So it makes it really, really challenging. So it's not really surprising, but there was a call to say, well, we should just get rid of them. There's no evidence behind them. But so we felt, well, that's not particularly helpful for you as a clinician on the ground. That's really unhelpful. And actually, so what could we do that would be more practical and pragmatic around those red flags? So what we did is that we got together with this really, really great group of people on the front there. And we basically used a consensus methodology to work out what would be in our framework. And so we looked at the current evidence, we looked at the systematic reviews in all of the spinal infection, Cauda equina, malignancy and fracture. We had to do an updated version for the Cauda equina, and we tried to do a systematic review in spinal infection. But again, there was not enough evidence to do that. But we did a scoping review. And what we came out with was 3 areas. One was risk factors within each of those areas, then the signs and the symptoms. And so we pulled out all of the red flags in association with those pathologies, and we sent those red flags out to a group of experts within each of those fields and asked them to give us which ones were most important. So we used like a Delphi design, essentially, to rank the importance of these red flags. When we got that back, we looked at that, and then we built some context around each of those red flags in each of those sections. And then we went out for peer review to ask people on the ground whether that was helpful or not to use. And so that's what we ended up with. And what we ended up with was really a model, a decision model that's a kind of a 2-step approach. And the first one is you've got to determine your level of concern. So basically, you're going to use the evidence from the risk factors and the signs and symptoms in the context of the evidence around those red flags. You're going to look at how those symptoms might progress and the urgency that you would need to move with that particular person, which will give you that clinical profile. And then very much in the context of how that patient presents to you, and that will give you that level of concern. And then what you've got to decide is what you're going to do with that. So the second step is really what's your decision. And there will be patients, obviously, there'll be no concerns, and you don't need to do anything, and you just carry on with your treatment. But bear in mind that you might need to reevaluate that over time. Then there's those patients who have a few concerns, but not enough to actually go and investigate them any further. But you're just going to keep an eye on them because something's really sort of just in the background for you. So a good example of that would be past history of cancer. So I wouldn't scan somebody just on the basis they've got back pain and past history of cancer, but I might just keep an eye on them to see how their symptoms develop over time. And so we do this watchful wait and we just monitor them. And then we've got this high level of concern where basically you've got to do something. Now that will depend on the pathology we're talking about and the speed at which you need to act. So if we think about the red one, then we're talking about an emergency referral, somebody who needs to be acted on the day. And a classic example of that would be Cauda equina. And if we think about those urgent referrals, then we're talking about metastatic disease. And so really, once you've made that decision, then you've got to make sure that your pathways are in place to actually action that and make sure they get to the right place as quickly as possible. And of course, we know that some patients will be on a particular pathway and then we'll just have to change that direction. That's what we're faced with all the time, with some of that uncertainty. And so as Sam said, this was published in, I think it was May or June of last year. And essentially what it's predicated on is good clinical reasoning skills. It's about making sure you have knowledge around those particular pathologies, so you understand how they might progress over time. And it's really good communication. So it's really important that you're asking questions around those specific pathologies and what you might see within them. Because this isn't a recipe, we're not giving you a recipe in this framework. It's just not possible to do that. And so if you can use your clinical reasoning and your understanding and that knowledge, then what it will do is it will highlight these pathologies. And what we're trying to do is to pick these pathologies up early. That's the key thing. So if we can raise awareness about those pathologies and catch these patients early, we're going to make a huge difference to our patients. So I'm going to hand over to Chris. She says, there we go.
Thank you, Laura. So I'm just going to pick up on some other work that we've been involved in and just talk through this. I've shamelessly stolen Dermot's slides, or a couple of them here, and I haven't even asked him, which is really, really naughty. But he'll be very happy because I'm promoting the National Low Back Pain Pathway Group and the National Low Back Pain Clinical Network. So these slides are from a presentation that Dermot and I did. And this is really just to bring up some collaborative work that we did around Cauda equina back in December of 2019. And that collaborative work had come around through a Twitter discussion and a Twitter, we'll call it a debate politely, that stirred up lots of interest, but actually ended up being one of the most positive outcomes from a Twitter discussion I'd had, because actually what it did is it brought together all these organisations, and what we tried to do is to bring these organisations together to talk about Cauda equina in primary care. So there's the Advanced Physio Network, there's the National Back Pain Pathway, there's GIRF, there's MACP, we'd have neurosurgeons, osteopaths, chiropractors, radiologists, patients, independent sector, private practitioners, chiropractors, everybody involved, everybody we thought had a stake in the management of Cauda equina patients. So we brought these people together in a room, really to discuss how we might better manage Cauda equina syndrome, because I think we all recognise that it's a condition that's generally not particularly well managed, and also it's a condition, as we know from some of the GIRF work, it's a condition that is extremely expensive in terms of medico-legal costs. But also we know from particularly Sue Greenhouse's work with patients who suffer with Cauda equina that it's a condition that has devastating effects. So for the patient involved in a poor outcome, it's devastating, but equally for those involved in the care of that patient, it can be devastating to be involved in the litigation and to see the patients come out with a bad outcome. So we got together on this consensus day to try and look at the front end of the pathway, because we know, and as Laura's alluded to, there's lots of discrepancy in the evidence around clinical presentation, and there was particularly lots of discrepancy around physical testing for Cauda equina. So what we tried to come up with was a workable and pragmatic recommendation for the management of Cauda equina, particularly in primary care. So for those of you who haven't seen the document, this is it. It's not in a very user-friendly format on a slide, but actually it's a user-friendly document if you get hold of it. And really what it's about is helping with the clinical reasoning process and in that decision making that Laura's already talked about. So it's pointing people in the right direction of signs and symptoms to look out for, and then what clinical examinations to do, and on the basis of that information, how to act. So it's almost like a safety netting document for clinicians. Okay, so if you haven't seen this, I would point you in the direction of this document for your management of Cauda equina. So things that came out of this, we talked, the whole initial discussion had been about bilateral radicular leg pain, whether bilateral leg pain was a red flag and whether that warranted urgent investigation. So what this framework does really nicely, if you look on the left-hand side here, it tells you the presenting signs and symptoms. So, for example, in the first box, acute or progressive bilateral leg pain with any other CES symptoms, well, clearly that's an emergency referral. That's a black and white barn door obvious. You'd be a numpty not to kind of referral. And second box here, kind of slightly less, no other overt kind of bladder and bowel sexual dysfunction type symptoms. We're looking at urgent referral as opposed to emergency, and we'll talk about some of that, I'm sure, in some of the questions. And then on the third category here, bilateral leg pain, but normal neurology and no other manifestations of Cauda equina, well, treat as per the radicular back pain pathway and safety net the patient. So we've got these. It's just trying to help clinicians, and there's no real science behind this. And I think that's pretty much where the international framework is. There's a little bit of science, but it's not as good as we'd want. So again, this is in a similar position to the international framework in that what it's trying to do is to help clinicians navigate the difficult decisions. So it's trying to help you to make a clinical decision. It's trying to help you to establish your level of concern, make a clinical decision, and balance risk. So a lot of what we do with these red flags, whether it's Cauda equina or the other red flags or other serious pathologies that we've mentioned, this is about managing risk and managing it sensibly and managing it in a reasonable manner. And that's what both of these documents try to do. With the physical examination, those two big things came with the Cauda equina. Two big things came out. One was about clarifying the issue of bilateral leg symptoms, and the other was around physical examination, where it was agreed amongst all the participants on this consensus day that digital rectal examination added nothing to the diagnostic criteria for Cauda equina. There was some discussion about it and perhaps having a role in secondary care. But in terms of helping the primary care or first contact clinician to make a decision about whether to put that patient forward for urgent MRI, it doesn't have a role to play. So since this time, we've stopped doing it as a physio team, and that's the recommendation. Although the recommendation is that saddle sensation testing is still carried out. So there was some good clarity came out of this, and this has gone into the National Low Back Pain Pathway document, and that pathway was launched towards the back end of last year. So again, if you haven't seen it, have a look through that. And at the moment, there are discussions between the National Low Back Pain Pathway and NICE in terms of trying to get this into one of the clinical knowledge summaries that are used widely in primary care from NICE to help steer management of Cauda equina. So I think we're probably making a bit of progress, but it's slow. So I think that's all from me. Just a quick run through those two documents. So now I think we have some questions from Twitter and email prior to today. So I think we'll start with some of those and then we'll pick up on your questions. So if you want to, while we're going through these other questions, put your questions into the Q&A box and we'll go from there.
Okay, so thanks Chris and Laura. I've got the first question. And this has come via email from Laura Groom. She says that she had a colleague who had this patient scenario in the A&E department. The patient is a 71-year-old with 1 week history of lower back pain, left buttock pain and paresthesia to both legs. They reported a 1-week history of difficulty passing urine, no saddle anaesthesia, no bowel changes. There's a 12-month history of bilateral lower limb heaviness, altered sensation, and no upper limb symptoms. Patient has normal neuro, upper limb and lower limb, normal bladder scan, normal PR, and urine test was negative. Laura's colleague wanted to scan the patient but didn't know if to do a same-day urgent scan or an urgent outpatient department scan. But the shop floor consultant advised no scan and referred back to own GP for further investigations. Given patient's symptoms and clinical assessment or of essentially normal neurology, Laura was wondering what Laura and Chris would have done regards to scanning.
Thanks, Sam. Do you want me to pick this one up first?
Yeah, go for it.
It's a difficult one. Did you say the patient was 71?
Yeah.
Yeah.
Okay, so I think it's a really difficult one because you've got lots of things in there that could potentially be red flags, and rightly, it was Laura, wasn't it, who asked the question? Laura's kind of raised some concerns. This patient's had bilateral leg symptoms, but they've had them for a year. So I think from the bilateral leg symptom point of view, if that hadn't changed, that wouldn't be a prompt for me to get this patient urgently scanned. What is a confounding thing for me is the 1-week history of urinary dysfunction. So then you've got to kind of balance, well, you've got a 71-year-old, what are the potential causes of urinary dysfunction in a 71-year-old? Was it male or female?
They don't actually, Laura doesn't actually say.
Okay, so it could be, if it's male, you might be thinking there might be some prostate issues, so you might be asking questions, well, you want to be asking questions about, about nocturia, about stream, about flow, about erectile dysfunction, again, which could be called equina or not. So you'd want to ask those questions. If it's female, you'd want to know a bit about their gynae history. You'd want to know about stress incontinence or urge incontinence. And if you think about the context of a 71-year-old male or female with urinary dysfunction, well, actually, that's a significant proportion of the population. I think it's a really difficult one without having the patient there in front of me. I think if there'd been an escalation in back pain or back and leg symptoms that coincided with the onset of the urinary symptoms. Yeah,
I think that's what I heard. So it's 1 week of low back pain and with the bladder changes at the same time.
Yeah.
Then I would be inclined to scan that patient. I think that's
reasonable.
I think that would be a reasonable thing to do. And I think the consultant that's seen this patient has made a risk judgment that actually they think it's low risk, and they may have some other issues and some other kind of information that might balance that towards a lower risk. If you think about those seesaws that Laura showed you, they might put them down this way a bit rather than up this way. So I think it's a difficult one. I think if we're thinking about who gets cauda equina, and I think this kind of alludes to the first question from Katie is about older people. 70% of people with cauda equina are under 50. So that would put this patient automatically in a less likely category. But if this patient's got back and bilateral leg symptoms and has had them for a year, they could be in that stenotic category. So stenotic patients tend not to progress to cauda equina, but they're clearly at risk of it. So I would probably err more on the side of caution with this patient, and I would have scanned them. I wouldn't have scanned them. I would have scanned them on the day. Oh God, that's a really difficult one. But I think given if you were going to coincide 1 week deterioration, onset of significant back symptoms and urinary symptoms, and there's no other extenuating cause, then I would push for a scan on the day. If there are kind of mitigating factors, then it might be an urgent scan.
Yeah, and I would probably agree with that.
So another question via email, and this comes from Gregor Ross, who says, are you aware of any guidelines on when you should urgently scan a patient post-op after spinal surgery to exclude spinal cord compression? In their experience, it is usually down to surgeon judgment, which can cause delay and poorer outcomes.
We're not aware of any guidelines with regards to that, and I think that's very much around clinical reasoning and clinical judgment. Actually, that's what I would say. I don't know if you want to add to that, Chris.
I just said it very much depends on the symptom presentation.
Yeah.
I think, you know, if the patient's not presenting with signs of cord compression, then it probably isn't. You know, so I think it would very much depend on patient presentation.
Okay, I have a question from Carl, who has emailed in. If a patient has Cauda equina symptoms for over 4 weeks, which has not changed in that period of time, am I correct in thinking the patient should not be sent to A&E? Is there any guidance or literature to support this? Thanks.
Yes, there is. If you read the National Low Back Pain Pathway, there's a timeline in there, Carl, that mentions a 4-week period. And again, it's a relatively arbitrary cutoff point. You know, this was a decision made by consensus, really. So if symptoms have been unchanged for 4 weeks, they've been present for longer than 4 weeks, but unchanged in that time, then the recommendation is the patient doesn't need an emergency scan, but they do need an urgent scan. So emergency, we're talking about same-day scanning. For urgent scan, we're ideally talking within the next few days, but that may well depend on what urgent means for your system. So, you know, for some people, an urgent scan might be next day, 2 days, 3 days. Some it might be within a week. But within the National Back Pain Pathway, it allows for that kind of urgent protocol for your system.
I have a couple of questions from Twitter. So this is from Camille. Is a foot drop a sign or a risk factor for Cauda equina syndrome? And on what basis would you decide if a foot drop caused by lumbar radiculopathy needs emergency referral, urgent scan, routine investigation, or physio treatment?
Chris, do you want to start that one off?
Yeah. So foot drop in itself is not a sign or symptom of Cauda equina. Associated with severe back pain and worsening neurology, maybe it is certainly an indication for urgent scanning, and sudden onset foot drop is an indication for urgent scanning, because that patient has muscle power if you're testing of less than 3 out of 5. So that in itself would be an indication for scanning, but not an indication of Cauda equina.
Thanks, Chris. I have another question from Amanda from Twitter. If a patient presented to spinal orthopedic clinic with thigh pain and lumbar spine MRI excluded nerve root compromise, would you do further imaging on the femur if there was a past medical history of cancer? Then she's gone on to say, I imagine it's not a straightforward yes or no, but would be interested on thoughts regarding further investigations and query bloods.
Okay, so I guess the question would be, if you were scanning because you were concerned that this patient had metastatic disease, then we would ultimately, what you want to do is you want to scan the whole spine in the first instance. We know that in terms of metastases, it's more likely to go to the spine, and it's more likely to go to the thoracic spine. So that your sensory level is not always where the metastases would be. So you would have to exclude the whole of the spine if that was your suspicion that's why you were looking at this patient. And so I would do whole spine in the first instance if that was your suspicion, if that's what you were looking for. And I guess the other question would be, and making some assumptions here, but if that was the only indication that you were concerned about this patient having metastases, then again I wouldn't be scanning them to look for metastases. If it was someone was coming with back pain and a past history of cancer, you need some more things to kind of think about investigating somebody, because if we investigated everybody with a past history of cancer and back pain, we'd stuff the whole system up. We would just scan a lot of people unnecessarily and worryingly. So I think it has to be based on more than just a past history of cancer.
Thanks, Laura.
Okay, Okay, I think that's all the questions that we had via email and Twitter. So do you want to move on to the Q&A? So the top question in the Q&A is from Christina, which says, can CES symptoms be fluctuating in the sense of intermittent saddle anaesthesia, lasting days to weeks that come and go, or intermittent changes to urinary function? What would the etiology be behind such symptoms if we are thinking true CES, or are the intermittent symptoms that last over a particular period of time reassuring?
So I was just going to, I'll start it off and then you can chip in. But yeah, you can have transient cauda equina. That is possible. I've seen that in a number of patients. I think you'd have to just be, you know, for someone like that, you've got to think about again about the risk of you know, that developing over time. So and you'd have to make some judgment about whether that was an emergency or an urgent scan. If those symptoms were sort of really transient, so they really were going away for days on end, I'd probably get an urgent scan done, but with safety netting that patient to make sure that they were seen in a timely manner. Don't know if you want to add, Chris.
Yeah, I'd agree. I wouldn't be overly reassured by symptoms that come and go. They're either, you know, they either have the symptoms or they don't. If the symptoms are present and deteriorating, then that would prompt me to act more quickly. If the symptoms are present, even if kind of intermittent but stable, then I would be less concerned. So again, it's a really woolly answer, which is probably really unhelpful. But I would say that the intermittent symptoms aren't reassuring at all. You know, they're still concerning symptoms that we need to then make a risk judgment on. And
I guess you know what, you might not send them to A&E, but you might send them for an urgent MR. And as Chris said earlier, there could be waits for that. I've just seen a comment in the box about in Northern Ireland the urgent waits are 3 months. Well, you know, that's quite a long time, and so again, you're going to be safety netting those patients. You know, they need to be absolutely clear about what to do should that, you know, deteriorate, and you know, tell them, you know, what you're looking for, and that way you can balance, again, you're balancing that risk up.
And I think what you need to, you know, to kind of follow on from that is Ailish saying about, you know, the 5 or 3 month waits or whatever, you know, long waits for an urgent scan. If you've then got to factor your kind of local circumstances into your clinical decision making. So if you have a suspicion or you're concerned that that patient may have cauda equina, you've then got to factor in the 3 month wait. Are you happy for that patient with stable potential cauda equina symptoms to wait 3 months, or do you think they need to be seen sooner? And I think that's when, you know, you then have to make that decision and push to get that patient an emergency scan as opposed to an urgent scan. So not only have you got the kind of quite difficult subjective, the difficult physical examination, the difficult kind of risk balance to make on that, you've then got to factor in what your local system can supply and provide, and build that all into your clinical decision about whether to push for an immediate scan or not.
Do you want to pick up this question? So if older people are less likely to have acute cauda equina syndrome, what age are we talking? Take note, I think 50 is pretty young. Quite right, Katie.
50 is very young, Katie. So I said earlier about 70% of cases of cauda equina are under 50. So you know, it is predominantly a younger person's issue, but not exclusively. If you want to have a look at some information around older people and cauda equina, then Christine Comer wrote a really, really nice paper around spinal stenosis and cauda equina, and there's a lot of information there about kind of confounding features as well. So it's well worth a read, and it's beautifully written.
So shall I pick this one up? So from an anonymous attendee, please can I just confirm with regards to the question Laura answered, if suspicion of peripheral metastatic disease, would you x-ray whole spine? No, I wouldn't x-ray, I would MRI. And I think, you know, if you're thinking you think it's peripheral Mets, then that's you wouldn't, you know, you might need to X-ray or you might need to MR that particular part of the body. We do know that and it will depend on the cancer. So we know that if it was a man, then it's more likely to go to the pelvis, and if it's a female, then it's more likely to go to the shoulder. So you might, if that's your suspicion, but I would still do MRI whole spine, because, you know, as we know, that's where it's most likely to go. Metastases is more likely to go there than anywhere else, but it doesn't mean it won't go anywhere else, but it's just more likely. And so you kind of, again, it's just about what your suspicion is going to be around that. But also just to clarify, X-ray is not necessarily helpful.
No, don't be falsely reassured by clear X-rays. You need 30 to 40% of bone loss to see lytic lesions on an X-ray, and I can't tell you, and I'm sure Laura would say the same, and a lot of people working in the same field will say the same. The number of people who've come through with normal X-rays and normal blood tests who have metastatic disease. So if you're concerned about metastatic disease, then MRI scanning is the most sensitive and specific investigation for you to do.
Yeah, and just to pick up on, I agree with Chris. I think the blood test, again, you can be falsely reassured. You can have someone with raging metastases and they've got, you know, normal blood tests, and we know about 50% will come back with normal blood tests and they've got raging Mets. So I think, you know, just be mindful of that.
Ellen's asked about reflex testing regarding bilateral radicular pathway. So in terms of reflex testing, yes, it's obviously part of your normal examination. It depends a bit on the age of the patient. If I had a 75-year-old with absent bilateral Achilles tendon jerks, then I wouldn't be overly concerned. If I had a younger patient, sort of under 50, let's say, you know, presenting the same, I might be a bit more concerned, but it wouldn't necessarily be the trigger to get me to scan that patient. I would be more concerned about people with bilateral loss of knee jerks, because it's a higher nerve root, so it would be less common. But if I found somebody with absent reflexes, then I would obviously check the upper limbs as well, just because some people might just have diminished reflexes generally.
We've got a question by Near here. 51-year-old female, lower back and bilateral leg pain with ongoing bladder incontinence, ongoing for the past 1 year. However, with further questioning mentioned more than the 6-month history of saddle anesthesia, although unclear. They did not mention this early as they were embarrassed or ashamed. With the above relative chronic symptoms, does this patient still require urgent escalation?
So
go on, sorry, Laura.
No, you go for it.
They need investigating, but they don't need investigating on the day if those symptoms have been stable.
Yeah, so they've had those symptoms for a long time. So yeah, I agree with Chris. They need investigating.
There's also another question from Neha, which says, what would be the action plan for the patient with clinical signs of CES, i.e. low back pain and bilateral leg pain, bladder incontinence and saddle anesthesia, but nil clear radiological confirmation? How would you manage or /safety net those patients? Do they need to be seen by a neurosurgeon or continue managing in physio clinic or discharge with safety netting guidance?
If they've got those symptoms and you've scanned their lumbar spine and it doesn't show cauda equina compression, then you don't have a reason for their symptoms, but you still have a patient with those symptoms. So what you need to do is consider whether you need to either scan up, so you investigate further up the spine to look for causes of those symptoms further up, or scan out into the pelvis. And very much dependent on how the patient presents will guide that decision. But you can't just leave that patient and assume that it was a a funny event, you don't have an explanation for their symptoms. So your duty of care to that patient is to find a cause. Is where I'd go, Laura.
Yeah, completely agree. I think, yeah, you need to find out what's going on for that individual.
Okay, we have a question from an anonymous person. When do we need to MRI or further investigation of spinal fractures that are seen on X-ray, e.g. if normal neurology, atraumatic elderly patients, can we presume osteoporosis, or should we be screening for other pathological causes of fracture? E.g. if history of cancer, do they need further tests? Should we routinely be checking for myeloma?
I think it's a really interesting question, because I think there's some debate and discussion around how we should manage those patients. I think, we know there's a high proportion of elderly patients who are going to have an osteoporotic fracture, and it's working out, whether it's been caused by something else, because fractures can look like myeloma. Myeloma and metastases can look like an osteoporotic fracture. So it's about that clinical decision about why you would look for metastases or why you might look for myeloma. Now, my trust, we've been asked by the rheumatologist to screen for myeloma if there's any sign of a fracture. So it will just depend on where you sit within your trust and what those guidelines are. But basically, it needs to be a differential diagnosis. You need to work out if it's one of those three things. And again, it's about that clinical reasoning and understanding that pathology in order to make some of those decisions. Chris, do you want to add to that?
Yeah, no, I think it's a good question. I'd agree with you there, Laura. I think your differential diagnosis for a spinal fracture, again, needs to be balanced in the risk with that patient. If you've got a 75-year-old underweight female who's been using steroids for a long time who has a spinal fracture, what's the most likely cause? The most likely cause is going to be an osteoporotic fracture, unless there are obvious features that it isn't, like lost pedicles or big lytic lesions. So again, it's about this risk stratification. What is the most common thing? What is the most common reason for spinal fracture? The most common reason is on osteoporotic fracture. What's next on the list is metastatic disease. What's next on the list is myeloma. So in terms of that kind of, how likely is it that this patient has this condition? Well, then you make that judgment. There might be other mitigating factors like a past history of cancer, or it might be that they're presenting with symptoms of myeloma if they're fatigued, or they're hypercalcemic, or they're constipated or thirsty, or all those other kind of manifestations. So I think you have to bring all of that kind of knowledge and background into making that kind of risk judgment. There's a really nice document by the National Osteoporosis Society on recognition of vertebral fractures. So again, it's a nice, easy read. So I would recommend that people kind of dig that out and have a read. It looks at kind of key features and key radiological features. Or also there's an excellent MACP radiology course that you can find out more about that. There's the plug, Sam. All right.
Okay, we do have a question from Fiona. Have you been bringing people in for face-to-face to check for neurology if they have subjective symptoms of Cauda equina during a remote consultation, or are you acting on the subjective assessment alone? Has the new way of working changed anything that you do in terms of Cauda equina?
So I would say that, again, it's about balancing the risk of bringing that patient in a timely manner. We know that the majority of the information that you're going to get from this patient is the subjective history. So that's what's going to give you, you probably by that point you've made a decision about whether you're going to act on those symptoms or not. So I think it's about weighing up the risk of bringing that patient in particularly within this period of time. Do you want to expose them to a hospital that might have COVID, or so it's that risk about seeing the patient. I would say there are some services that I know are asking that neurology is done before they get seen or they get sent on to have any further scanning or anything. So again, it will depend on what your service requires. But I personally wouldn't bring them in if it delayed their care. And I recognise that they needed to go to the emergency department to have a MRI scan because I was suspicious of Cauda equina.
And we probably do it slightly differently in that we would bring people in and then do a neurological examination. And again, it's, as Laura says, it's not really that it's going to change our kind of hypothesis, but what it may do is give us more supporting evidence, so that when we do pick up the phone to the emergency department, then we might have a bit more evidence that might help that patient get into the scanner a bit quicker. So again, it's just about, we're based in secondary care, so the ED is down the corridor, so there isn't really a delay to that patient's journey. So that's the key thing, really, is your intervention going to delay that patient's journey? Well, if it is, then it's a pointless intervention.
Yeah, and so I agree, and I think I'm sitting in the community, so they'd have to come to me and get bounced out. So it's it really is about that delay potentially.
Okay, so the next question is about communication, which you discuss in the framework. And it comes from David Stevens, who says, would you ever consider asking a patient to read line by line the Cauda equina warning card in order to get a better clarification on bladder bowel symptoms?
Yep.
Yes, thank you, David.
Simply yes. I mean, you've got to, again, it's about weighing up the understanding that patient has got from your communication. So if you don't think they're getting it, then you need to find a different way of them to get it. And we've got really good examples of patients whose English is not their first language, and actually what we've done is we've given them the Cauda equina cards that are in different language, obviously in their language. And so I think it's really important that you're absolutely confident and you're clear and you're happy that they understand what you're asking. And if you're not, then you need to find a different way to do it.
Yeah. And I think it's about, it's what you're asking and why you're asking it. So context is everything. So unless you've set it up, getting them to read the questions out is not going to make any difference. So you need to set the questions up as well. So your safety netting or your kind of advice and that questioning around these sensitive subjects is really about setting the whole thing up. The patient needs to know why you're asking about their sexual function when they've got back pain. So without that context, when they read it, it's still not going to be relevant. So it's about making it relevant, whether that's in context or language.
Thank you. We've got a question from Baljit. If you consider spinal metastases, would you do a whole spine MRI and send for bloods at the same time, or would you wait for the MRI results? And what blood tests would you do? So
I would do it at the same time. Basically, if you're suspicious that someone's got metastases, whole spine MRI and do some blood tests, and you can do hundreds of blood tests, but actually what you want to know is, have they got some inflammatory markers raised? So look at your full bloods, ESR, CRP, and as I said, there are other things you could do, but just bear in mind, what we said earlier is that they may not be helpful. They may be normal. So you just got to, again, weigh up what you can do, and again, what does your service allow you to do? And if you're going to request these things, you need to understand and interpret them as well. So, but yeah, I would do the same time. I wouldn't wait to do another test, because again, that's potentially, if that scan comes back with Mets and you're then saying, well, I'll just do, I'll do some bloods, it's not really much point really. So you might as well do them at the same time.
Yeah, I'd agree. And I'll probably throw in a bone profile and liver function test as well. Yeah.
So we have a question from Adam. In the framework section, RE spinal infection, it mentions a risk factor of spinal or abdominal surgery. Is there a time frame in regards to when the surgery was completed that will increase the risk of infection?
I think that's a really good question. And I'm not sure I can give the answer with some research backed up, because actually what we see is we see it very quickly after surgery, and then we can see it years down the line. And there may be an assumption that it's the surgery that's caused that infection, of course. So if you've got someone that's had it, had spinal surgery a year previously, was it the surgery or not? Difficult to know, but I've certainly seen, that correlation. So we know that it's a risk factor. So you can look at it that way.
And I think that there are a few papers that look at post-surgical discitis, and the majority of those are within the first 1 to 2 weeks. But as Laura says, that's the majority, but that means there's still a significant minority that aren't. So don't discount it, I think.
Yeah.
Okay, so I have a question from Adam, which says, in the framework section, re spinal infection, it mentions a risk factor of spinal.
Sorry, Sam, we've just answered that one.
Oh, sorry.
Sorry, next.
Thanks. Okay, so this one's from Anonymous, and it says, thanks for taking the time out of your evening to do this. Where can I find the guidance which you have talked about with the CES signs and symptoms which have been stable for longer than 4 weeks? Is an urgent, not a same day A&E referral? I cannot find it on the National Low Back Pain paper.
If you Google the National Low Back Pain and Radicular Pathway, you should be able to find it. If not, then I'll send the links through. I'll pass the links through to the MACP team who can forward the links to attendees. Is that right, Sam? Does that work? Yep. Thank you.
Question from someone anonymous. Does it count as a written safety netting if you send the Cauda equina syndrome information to all patients at the point of referral into the service?
No, well, no. I think so. I'm reading this as that you haven't actually seen the patient, so you're sending them something that has no context. So they don't know what you're potentially talking about, and we wouldn't send Cauda equina syndrome information to every single back pain patient, because again, that's not helpful, because we know that it's rare, and so therefore you need to rationalize why you're sending or talking to that patient about Cauda equina syndrome and why you're safety netting them. So I would say no. And
I would argue it's not safety netting.
No, it's just information.
That's safety netting is a specific context, is contextual, and if you're sending it out to everybody, there isn't real context other than the fact they've been referred. So what you're sending out is information rather than safety netting. So I think from a clinical perspective, it's not really safety netting. From a medico-legal perspective, you'd probably argue it, or you could argue that it wasn't really safety netting. Sue did a really nice paper last year on safety netting in musculoskeletal science and practice, which kind of looks at some of the issues around safety netting in COVID context, but also safety netting as a concept. So that might be a good resource.
Okay, so next one is from Anonymous. It's, what is the reason you would scan the pelvis if a whole spine MRI is NAD and patient still presents with CES symptoms?
I'm itching to ask the question back to anonymous attendee. So what would be your reasons? But my reasons would be that intrapelvic pathology can cause Cauda equina symptoms, can cause bladder and bowel symptoms, can cause pressure on the sacral roots, and mimic Cauda equina. So we've seen numerous cases of visceral, particularly gynecological bowel pathology, masquerading as or mimicking Cauda equina symptoms.
Another question from someone anonymous. Are we any closer to routine DRE and perianal sensory testing in primary care to protect emergency services, given that these are two routine tests carried out in the ED when CES is suspected? I'm aware it's not mandatory in current guidelines, but could this reduce referrals and therefore reduce the burden on ED?
No is the answer. I think no, it couldn't, and it shouldn't. Laura's talked about Cauda equina being a predominantly subjective diagnosis. I don't think, we would kind of talk through the consensus day that the DRE has no role in terms of helping that patient through the pathway. It has no correlation to positive MRI scan findings, so it really doesn't have a role in us getting that patient to the ED and onto scanning. There is some evidence from Michelle Angus and her group up in Salford that saddle sensation testing may have a correlation with positive MRI scans. So that's why the saddle sensation testing is being kept in the national pathway.
I think it just goes back to the whole premise of the framework and the pathway is around early identification, and so we want to catch these patients when they've got function, they've still got function of their bladder and bowel, and doing your DRE is it's going to tell you function or no function to some extent. So it's not particularly helpful within where they are on that pathway or how severe it is. So it's about that early identification. We don't want them to be in a situation where they've lost control. That's that's not in our interest. So we are very reliant on that subjective story that they're giving us.
Okay, we have another question from Bhagyai Shri. So did you mean in acute foot drop without bladder and bowel, saddle anesthesia, it warrants urgent referral and not an emergency referral?
I think that was me. I was saying it's not an indication of Cauda equina, so you wouldn't be asking for an emergency scan for Cauda equina, but you would want them urgently scanned because they've got significant myotomal weakness.
Great.
Okay, we have a question from, I'm not sure I can pronounce the name, sorry. Is there any data on the importance of clinical experience in identifying serious pathology? And if clinical experience is significantly important, how do we best train junior staff to protect them?
So I think there's there's stuff around, we talk about gut feeling. Or a suspicion, and often that suspicion is based on more than a gut feeling. It's based on a presentation that you might have seen, a story that you've heard before, or something that doesn't quite fit. And it often, what we want is to fit these patients into a box, and they, part of that story doesn't fit. So I think, clearly clinical experience is important, and it is about knowledge, but you can have lots of clinical experience and still not pick up serious pathology because you've not, you may not understand how that pathology might progress or how it presents. So it's about raising, in my opinion, I think it's about raising awareness about this is a possibility. And if it's a possibility, what do I need to know about that serious pathology and how it might present? And I think it's important, like all of these things, you have to learn these things as you go through your career. And we should be exposing everyone to this, actually, because in our opinion, this is going to happen more. We're going to see more patients with serious pathology as time goes on. We know it's related to the older population. Our population is getting older, and so it's likely we're going to see more serious pathology. So I think, clinical experience is important, but it's that context around the clinical experience, what you're learning within your experience.
Yeah, I'd agree. I think pattern recognition is really, really important. And I can't remember the paper, but there were some papers that said, listed some red flags and, which was most important to help people identify serious pathology. But the biggest factor was kind of clinical gut feeling. And that's built on pattern recognition and experience. But as the questioner suggest, it's difficult for less experienced people. So what we need to do as more experienced clinicians is to provide a framework to help, and kind of scaffold that thinking and scaffold that clinical reasoning. So I think that's where our role is to help people, so they're very clear about what the red flags are, clear about what to look out for, but clear about the context as well.
I've got a question from someone anonymous. In this area of COVID and virtual appointments, do you have any tips or tricks to help support decision making where physical examination is not possible? I fear that not seeing patients in person may mean some of the cues that triggered concern in the past.
Yeah, and I think that's it's a good question in that I think there is some anxiety about, I can't see the patient, and therefore I'm going to miss some of these things. And I think I understand that worry. I think sometimes you can look at a patient and you can go, you're not well, or you'll see something and they'll smell different, or so there are things that we would pick up when we actually see someone face to face. But actually, ultimately, we'll go back to this, what we said earlier, is that the majority of picking up serious pathology comes from your subjective examination. So it's that questioning that is critical. It's picking up on the patient's cues and giving them time to answer your question, and not to fill the void. Let them answer the question, and you pick up on the cues that they might give you. So you're really kind of using your ICE, your ideas. I can't even remember now. ICE. Concerns and expectations. So you want to know, is there something going on for them? You push it back to them a little bit, but I think that subjective is critical, and give them space to answer some of the questions you're asking them.
Okay, we've got one more question, and I think that will be the end. So this comes from an anonymous attendee. If strong subjective signs and symptoms point to CES with bilateral symptoms, how essential is saddle sensation testing? The reason why I ask this is because of the unpleasant experience this can be for both patient and clinician.
The bottom line is, that's probably not the right probably quite apt. So the bottom line is, is it going to change your management? Probably not. Okay, so it goes back to the answers I gave earlier. I think, if you're in a position to be able to test the saddle sensation at the time of the history taking, that may strengthen your case to get that patient into the MRI scanner. The other advantage of being able to test the saddle sensation is that you then have a benchmark. So that patient's saddle sensation may well deteriorate from the time you see them to the time they get seen in A&E or by the surgeon. So it's a way of quantifying change. So I think that it does add to the picture, but is it a keystone to your kind of decision making about whether that patient needs to be seen in the ED and have an MRI? Well, no, it's not. I've had some questions recently about whether you need to test or we get the patient to test. Well, those are both options that you can consider, and particularly kind of these times with telephone consultations. So you could consider asking the patient to do light touch themselves around the saddle region. So you can be a bit more creative if it's going to be helpful. But absolutely, it's not a be all and end all.
Yeah, and I would just add to that I understand why people are cautious or don't want to do these testing, but it's no different to any other sensation testing you do anywhere else on somebody. So it's not complicated. It's just a bit more personal, and you do need to make sure that you have a chaperone. So if a chaperone is not available, then you shouldn't be doing it.
Okay. Thanks, guys, and just leaves for me to say thank you both for giving up your time for tonight to do this. It was really engaging. I certainly really enjoyed it, and I'm sure everybody else did. There's been some positive comments coming up through on Twitter and on the chat on here, so I'm really pleased that we held this event tonight. And also just a thank you to Kamal, Sinead, David, some of the PDC, or all of the PDC, including Feroz, Basil and James, for helping to get this event going. Yeah, so thank you everyone, really. That's it.
Thanks, Sam, and everyone for organising.
Yeah, thanks for inviting us.
Yeah, my pleasure. Okay, so thanks everybody. Goodbye.
Bye. Bye.
See you later.